Thank you very much, Mike, and thanks to PK and Dirk for the kind invitation. So all I have to say is just cover it and forget it. So I hope to, in the next few minutes, convince you that these long, complex lesions may in fact be the sweet spot for covered stents. We know that there are a number of problems with bare metal stents, increasing stenosis with increasing lesion length, and obviously that process doesn't stop at 12 months but continues up to about 3 years. And so there have been a number of different technologies, including drug-eluting stents, for example. The Zephyr trial was a registry from Japan, a very large number of patients with an average lesion length of about 17 centimeters. And they used intravascular ultrasound and quantitative angiography in the majority of their studies. And what they found, interestingly, was that if you had long lesion lengths of more than 16 centimeters, and if you had a small stent luminal cross-sectional area and a small artery, if you had 2 or more of these risk factors, the primary patency rate dropped way down to about 29%. We already heard from Dr. Scheinert about the real PTX study. Again, rather disappointing results out to about 3 years. The Eluvia drug-eluting stent, this is a paper that was published just this year from Dr. Sorcello's group in Munster, Germany, and a very impressive early primary patency rate at 1 year, but of concern, a note of caution here, was this 8% aneurysm formation rate. The IMPACT Global long cohort, DCBs are great, but with longer and more complex lesions, the bailout stent rate really is quite high. In fact, pushes 50% for these very long lesions that are more than 25 centimeters. And again, you can see that there is a drop-off in primary patency rates at 1 year, down to about 64% with these longer lesion lengths. The SFA long study was an Italian multi-center registry with average lesion length of about 25 centimeters. About half of these were CTOs. And again, for these very long lesions, you saw that there were more modest primary patency rates. This, of course, was from our colleagues in Leipzig, a real-world registry, average lesion length about 24 centimeters, and about 24% of these patients did require adjunctive additional stenting. And there was a pretty dramatic drop from 79% primary patency down to about 53% at 2 years. So pretty significant drop between 12 and 24 months, and leading them to, I think, accurately assess the situation by saying that DCBs, while safe and effective, delay rather than prevent restenosis in these more complex lesions. And then, of course, the combination of the Supera stent with drug-eluting stent, this was the RAPID trial, which was reported earlier this year at the LINC meeting. And again, at 24 months, you saw about 75 versus 62%. So certainly acceptable, but not that particularly outstanding. So what about good old-fashioned Viabahn for treatment of these long lesions? Well, the Viper trial was a study done in the United States looking at the newer generation device with the proximal contoured edge and the radiopaque markers. The hope there was that this would result in improved flow dynamics on the proximal end. And again, real-world lesion lengths here, about 19 centimeters, over 50% of these were occluded, and the primary patency rate was 74%. However, there was significant oversizing noted in over 30% of the patients that were enrolled in the study. And so if you look at whether the device was implanted properly, i.e. was not oversized by more than 20%, you found that if you played by the rules and you didn't oversize it, you were rewarded with a primary patency rate of 88% on the proximal end, 87% on the distal end, and as is true of all the Viabahn studies to date, patency is independent of lesion length. The 25 centimeter extremely difficult patient cohort, nearly 100% occlusions, 27 centimeter lesion lengths with a 67% primary patency. Viastar, of course, was the definitive randomized trial of Viabahn versus bare metal stents. Again, real-world data, 19 centimeter average lesion lengths, about 80% of these were CTOs, 72% task C and D lesions. And you can see a very significant benefit in terms of covered stent versus bare metal stent, particularly in those lesion lengths of more than 20 centimeters, 27% versus 65% primary patency. So a very dramatic difference. More recently, the Viabahn IDE study was presented by Dr. Oki. Again, long lesion lengths here about 22 centimeters, and they were required to either use IVUS or quantitative angiography for vessel sizing. And you can see a significant benefit with that approach in terms of their primary patency, with 88% at 12 months and 79% at 24 months. So proper sizing is really of paramount importance, as illustrated on this slide. So if we look at the role of bare metal stents with regards to restenosis, we can see that there in fact is a linear relationship there, so that the longer the bare metal stent, the higher the likelihood of restenosis. But that is not the case with covered stents. And it's important to remember that there's a significant difference between restenosis of a bare metal stent and a Viabahn. A Viabahn is typically going to be very short focal edge stenosis versus a more diffuse proliferative response. And it's also important to remember that stent fractures, virtually not seen with covered stents, but can occur in up to 37% in some reported series in the literature. And then finally, a very promising new technology on the covered stent theme would be the PQ bypass. This was a DETOUR 1 trial that Dr. Shiner presented at the LINC meeting earlier this year. Super long lesion lengths of about 25.9 centimeters, 100% occlusions. And there were no DVTs, and essentially, as you know, with this technology, you're basically going from the ostium of the SFA into the vein and then back into the above-knee popliteal artery distally, and with a primary patency rate, despite these very long lesion lengths, of 84%, which is pretty impressive. And then finally, covered stents versus the gold standard of venous bypass grafting. This was a Super B study presented by Dr. Reinen, and you can see there was really no difference between the two groups in terms of patency, but also in terms of mortality, ABI improvement, walking impairment, and quality of life. And in fact, there was less morbidity and a shorter length of stay. So in summary, we can say that while atherectomy, DCB, bare metal stents, and drug-eluting stents are all effective therapies for short to medium length lesions, the results for long fempop disease are more modest, with significant patency attrition over time, and we now have level 1 evidence that covered stents are superior to bare metal stents for long fempop disease, and that stent grafts still remain an excellent treatment for these longer lesion lengths and more complex lesions. Thanks very much.